This is a chest radiograph of a patient who's had prior spinal surgery with fusion of the lower thoracic vertebrae. Now, the most striking feature here is a rounded mass seen behind the heart. This is definitely something we need to investigate further, especially considering the spinal hardware in place. It's hard to separate the medial border of the mass from the vertebral column, and while the lungs appear otherwise clear, this mass is quite suspicious. One differential we should consider here is whether this mass is originating from the lung or the mediastinum, or if it's related to the spine itself. Given the spinal fusion and hardware, a paravertebral origin seems most likely. The possibility of a neural tumor, like a nerve sheath tumor or neurofibroma, should certainly be considered, especially since these are often paravertebral in location. Now let's move on to the MRI images. These really help clarify things. We can see that the mass arises from the lateral margin of the spinal column and involves the neural exit foramen. This really supports our suspicion of a neural origin. The mass looks well defined at the margins in most areas, but is poorly defined where it enters the foramen. The signal characteristics are telling us a lot here. T2 hyperintense and T1 isointense compared to muscle, with some cystic components in areas of non-enhancing necrotic tissue. All of this points strongly toward a neural tumor, likely recurrent given the history of previous resection and spinal stabilization. So, to wrap this case up, my leading diagnosis would be a recurrent nerve sheath tumor, likely either a schwannoma or neurofibroma. We've got clear imaging findings that align with this, and it fits well with the clinical background of previous spinal surgery. If I were in the Viva exam, I'd definitely anticipate questions around the differential diagnosis of a paravertebral mass. The examiner might ask about how I would differentiate between a nerve sheath tumor and something like an abscess or metastasis. In that case, I would explain that the clear, well-defined margins and enhancement pattern, along with the patient's history, really help steer us toward a neural tumor. If this were an abscess, we would expect more ill-defined margins and perhaps signs of infection elsewhere. Metastasis would more likely present with destructive features or multiple lesions. The examiner might also probe further, asking about management. For this case, I discussed the role of a multidisciplinary team approach involving both the surgical and oncological teams. A biopsy would likely be considered to confirm the pathology, and surgical resection might be necessary if the mass is causing symptoms or there's concern about malignant transformation. Lastly, I'd expect the examiner to ask about other imaging modalities. I'd mention that while MRI gives us great soft tissue detail, CT could be helpful to assess any bony involvement more clearly, especially in the context of previous surgery. That's it. I'd love to hear your thoughts, and if you have any questions or additional points, don't forget to drop them in the comments.